Today we're going to talk about type 1 versus type 2 diabetes. One of the first questions might be, who cares? We all should care. You know, there's an interesting couple of points. Here's a couple of reasons. By far, the number one cause of death is heart attack. The number one cause of permanent disability is stroke. The number one cause of both of those, prediabetes. Now, another question is that, so most of us are going to get this, believe it or not, if we get old enough. Age is very much related to causing type 2 diabetes. But again, one of the reasons that people ignore and don't understand their risk for type 2 diabetes and what's going on is they hear the word diabetes and they think type 1 diabetes. Two very, very different things. So today we're going to get into what is the difference between type 1 and type 2. Another big difference is, again, even though most of my patients, they have prediabetes type 2, most of them will never go to needing insulin. Another big, big deal, big difference between the two. So there's a lot of things to know about type 1 versus type 2 diabetes. There are obviously two main types of diabetes, type 1, type 2. Both are chronic disease, both affect the way you metabolize blood sugar. According to the 2017 National Diabetes Statistics reports, there are 30 million people in the US with diabetes, less than 10% of the general population. 90 to 95% of these diabetics have type 2 diabetes. But I would tell you, I'm going to go off script for a second and just remind you, number one, that's way underdiagnosed. There's a good case to be made that there's maybe double that. Even 3 years ago, before some new information came out, even a conservative group like the CDC said there were probably at least 80 million pre-diabetics in the US. And that was looking at just information that they had at the time. And that was before the information came out from UCLA indicating that once we're beyond age 30, up to half of us have significant pre-diabetes. Now, here's one thing to remember. Most of us will continue to have pre-diabetes when we're aging into type 2. Most of us will not go on to complete or frank type 2 diabetes or full-blown diabetes. Now, why does that matter? Unfortunately, it confuses most people because most people don't think that pre-diabetes is dangerous. Pre-diabetes rots and burns our arteries, just like full-blown diabetes. That's where one of the major health problems is, one of the major concerns, because people do not understand the seriousness of pre-diabetes. But let's go on. Let's go back to the bullets in the script here to talk about the differences between these two, because they're actually two very, very different disease processes. One is, type 1 is attacking the source of the insulin. The other is attacking what we do with insulin. It's a slow degradation or wearing out of our insulin receptors. Now, the percentage of both of these increase with age. In fact, most people think that type 1 diabetes doesn't happen after age 50. That's not true. If you look at the actual statistics for type 1 diabetes, that's where we develop usually an autoimmune response. It continues to happen on into the 50s and 60s. In fact, a friend of ours had type 1 develop just a couple of years ago. How did we know it was type 1? How did the doc know? Again, by looking at the actual insulin development itself. She went from zero problem in this area over a 2 to 3 month period to where she was just not producing insulin. That is not a typical type 2 presentation. So percentage increases with age of both of them, but especially with type 2 diabetes and prediabetes. Among 65 years and older, the incidence rate reaches as high as 25%. Again, this is full-blown diabetes, and prediabetes is much, much higher. If you'd like to get some statistics on that, figure out what portion are over 50%, what portion over 65 have prediabetes, start taking a look at books like The Diabetes Epidemic in You by Joseph Kraft. He showed that it was way over half. and it continued to increase as we age. In fact, many people think that the type 2 diabetes epidemic is associated with obesity. Obesity is a strong driver, there's no question. But what most of us forget is that aging is also a very strong driver. Men and women get diabetes at roughly the same rate. Incident rates are higher among certain races and ethnicities. People of color, American Indians, Alaskan Natives have the highest prevalence. Black and Hispanic populations have higher rates of diabetes than non-Hispanic whites. Testing and monitoring blood sugar are essential for diabetes management because it's the only way to know if you're meeting target levels. Now, here's some more comparison components. Type 1 diabetes, people don't produce insulin. It used to be known as juvenile diabetes. And classically, you don't see type 2 diabetes happen that often in the juvenile or teenage or second or third decade of life. Type 1 diabetes usually develops in childhood and adolescence. It's possible to get it later in life, as I mentioned earlier. With type 2, people don't respond to insulin as well as they should. Later in the disease, they often don't make enough insulin. In other words, what happens with type 1 is that your body loses the ability to make insulin. What happens with type 2 is your body still makes insulin, but it becomes resistant to it. That's where the term IR, or insulin resistance, comes from. If you go along with type 2 or insulin resistance for long enough, your beta cells basically just wear out. They stop making insulin. With both of these diseases, they are terrible on arteries. Again, both of them cause inflammation. Both of them cause damage to that intima, that endothelial lining of the arteries. Back to some comparisons here. Symptoms of type 1 diabetes develop fast, typically over the course of several weeks. As you remember, the example that I brought up with our friend in her 50s, no problem, and then over a 2-month period, she went into full-blown type 1 diabetes. People with type 2 diabetes don't do that. I will typically see people go for decades, not months, not weeks, not years, decades, slowly developing into prediabetes, and then some of those go on to full-blown diabetes. And you don't have symptoms with prediabetes. You're burning up your arteries, but you don't have symptoms. Another major source of human suffering and disability. This is going on inside. It's like that old adage of how do you boil a frog slowly? We're boiling slowly from the inside with prediabetes. Now, interesting, again, comparison between the two in terms of causes. The vast majority of type 1 appears to be caused by destruction of the insulin-producing beta cells. The guy in the video called them beta cells in the pancreas. With type 2, factors contribute. Excess weight, excess body fat is a big, big deal. Genetic factors, 9p21 has a major component of risk for prediabetes. Environmental factors are a big issue. I was born as a 10.5-pound baby. Every ounce over 8.5 pounds is a significant risk for prediabetes and diabetes as you get type 2 diabetes as you get older. So environmental issues, genetic issues, epigenetic issues, they have actually demonstrated that in laboratory animals, if the father was obese at the time of insemination, the infants tended to have prediabetes. Now that was lab animals. Obviously they haven't done that with humans, but there's significant epigenetic components. Now what's the major risk factor that we didn't mention? And we've mentioned it multiple times in other places and even in this video, but we didn't mention it now and it's not in this bullet. Aging. Aging is the #1 risk factor for type 2 diabetes, prediabetes. Risk factors, family history, age, geography, genetics. With type 1, again, there does appear to be a genetic predisposition. We've talked many times about friendly fire, our immune system causing inflammation and attacking parts of our body when it's protecting us from outside diseases. There does appear to be some genetic predisposition for this, and that appears to be a major cause of the problem with type 1 diabetes. Maybe some cross-reaction of antibodies and T cells, other immune functions between viruses, other external infections, and the beta cells themselves, just like you have with rheumatoid arthritis and inflammatory bowel disease and many other psoriatic arthritis, many other inflammatory diseases. Now, what are the risk factors for type 2 diabetes? Prediabetes, overweight, obesity. Well, obviously, if you're already going down that path, you're more likely to get it. Family history, age, physical inactivity, tons of things. We've already talked about racial inequalities in this space. And we've already talked about, I gave the example a minute ago myself, a baby weighing more than 9 pounds. So treatment. For type 1, there is no cure. Insulin must be regularly injected. For type 2, that's a whole different story. Again, most of us with type 2 are never going to need insulin. Most of it can actually be reversed with diet, exercise, loss of that body fat. If lifestyle changes aren't enough, you get some help from medications. Several of my folks, for example, are on pioglitazone. A lot of folks take metformin. A lot of them take metformin for just preventive reasons. I know there's a lot of debate about that. I take it. I have known prediabetes. There's a thing called the TAME study, targeting aging with metformin. It was developed basically because of this issue, that prediabetes and diabetes are so common as we age. And metformin is such a safe and helpful drug for that item, for that risk factor. So how do you diagnose? There are antibody tests that you can use for diagnosing type 1 diabetes. Hemoglobin A1C is the most commonly used test. It's unfortunate because it's a bad test to rely on for whether or not you have prediabetes or even diabetes. One of the major problems with hemoglobin A1C, it's great for use. Again, like any lab, you have to know how to interpret it. Unfortunately, most doctors today think that, well, if your hemoglobin A1C is 6 or less, you're okay. No, the vast majority of prediabetics have, with significant arterial disease, have hemoglobin A1C values in the mid-5s. So if you have a hemoglobin A1C in the mid-5s, 5.4, 5.3, 5.5, 5.6, I strongly suggest that you get a much better understanding of what's going on with your glucose metabolism. You know, there's that old saying, if what you don't know can't hurt you. Not at all true with this. What you don't know about your blood metabolism, your glucose metabolism, can and does hurt people. Again, most common cause of death, most common cause of disability. And guess what? Who has ever known when they were forming plaque? We don't feel it. We don't know it. It's totally asymptomatic. Fasting plasma glucose is also used. In other words, the fasting blood glucose. In fact, these two things are the things that are most often used by docs to, quote, diagnose sugar, end quote. And again, both of these are woefully inadequate in terms of us knowing whether or not we're burning our arteries with glucose problems. Random glucose. This is used occasionally to diagnose diabetes, but at least that is not that popular. That's a terrible test for it. The OGTT is a much better test. And Kraft Insulin Survey, both of these are very, very good tests, giving you an actual stress test of your glucose metabolism. You start getting the basal glucose or the fasting glucose, and with the Kraft Insulin Survey, you get insulin or fasting or basal insulin as well. Then you take a challenge. With the OGTT, it's typically 75 grams of glucose. With the Kraft, it's typically 100 grams. With the OGTT, you get the glucose 1 hour later and 2 hours later. Now, the perfect metabolism, optimal metabolism would be a fasting glucose 90 or less, peaking at 120 or less at 1 hour, and back down less than 100 at 2 hours. The Kraft Insulin Survey goes on for 3-4 hours if the patient can show that much patience. And it's helpful to do that because one of the things we realize is that there's a pattern where we slow down our phases of reaction to glucose. What we'll often find is that their glucose values will continue to climb at hours 1 and 2. 2.5, even 3 sometimes before they start coming back down. That's the reason that Joseph Kraft changed his glucose tolerance surveys to add that extra time period. So many people were moving their phases back. Here are the basic differences between OGTT and the Kraft Insulin Survey. OGTT, with both of them, you get a fasting. You fast for at least 8 hours, and then you do the glucose challenge. The OGTT, you're looking only at glucose, getting an insulin value every time you get a glucose value. As I mentioned before, with OGTT, you're challenging the body with 75 grams. With Kraft Insulin Survey, you're challenging the body with 100 grams. Bottom line, the Kraft Insulin Survey is a better test. What do we get? We do have access to the Kraft Insulin Survey. It's a little bit messier, a little bit more time consuming, an at-home test. We get it through Meridian Valley Labs. But most of our folks go to a local Quest, and you get it. It's quicker, it's easier. It's a slightly different variation of it, but we do get insulin values. I've been working with Quest Labs for a year or two, working to get that insulin value because it's so important. Sure enough, every month we'll get 1 or 2 people who had relatively good glucose numbers. Their insulin values were just way out of kilter. What are the insulin values that you'd want to see? Basal insulin or fasting insulin should be 5 or less. That half hour, 1 hour, 2 hour peak, whenever that peak occurs, optimum peak for insulin values would be 50 or less. And then you'd want to get back down to 20. So 5 or less, 50 or less, and then 20 or less at 0 or fasting 1 and 2 hours. Now, what do we tend to see with some of these folks that are having problems? Again, as I mentioned, some of them have pretty close to normal glucose numbers, but insulin values peaking way up around 100, 150, 180. Obviously, if you're getting those kind of numbers, your insulin receptors are not working well. So again, very, very deep discussion, detailed discussion on this. That's part of what we do with the webinar for inflammation and prediabetes. Here's some other people's versions of diagnoses on this. If you look at the ADA, they'll say anything below 5.7 on a A1C is normal. Prediabetes is 5.7 to 6.4. Again, if your A1C is 5.4, still be very nervous. Make sure that you get clarity on what's going on with your glucose metabolism. Fasting glucose, again, they say 99 or below is normal. No, in the 90s, you've got prediabetes. Oral glucose tolerance test, 140 or below. Again, if you peak at 140 in an OGTT, that's actually pretty good. The vast majority of people that I work with don't have that good a number. But again, as we mentioned a few minutes ago, if it took you getting your insulin value up to 150 to keep that glucose at 140, that's a problem, a very significant problem. There have been many viewers that have commented on this and made the comment that there's clearly evidence that hyperinsulinemia, too much insulin in the blood, is inflammatory, just like having too much glucose in the blood. Those are the kind of examples that clearly demonstrate that. You'll get these people that peak at 140 or less in terms of glucose, but they get very high insulin levels and they have significant plaque. So again, these are some of the numbers that you need to be aware of, you need to be thinking about. And that's how to tell the difference between type 1, type 2, and that's how to diagnose them. The point behind this slide is there's an image. We've got plenty of videos on prediabetes, how to diagnose prediabetes, what kind of damage it can cause, and some of the things to be thinking about. There's nothing like a community. We saw that in the Louisville event. People got together and started talking about how they've had challenges and successes in preventing their own heart attack, stroke, or chronic disease. It became very clear that You don't have to be a doc with a full-time 30-year career in preventive medicine to understand this and successfully prevent heart attack, stroke, the number one killer and disablers of people. You don't have to be a physician to prevent eye disease, kidney disease. All you have to do is think, listen, and become part of the community. Now, how do you do that? Go to the membership login on our webpage, and as you can see, you can get right in. You have to sign up if you haven't signed up already. And I've already signed up. I've already gone in. It's very simple, very easy to understand. In order to help encourage this, after the success and the positive emotion, the positive impact that we're seeing with these events, we're saying, look, we need to offer more of these services for free in order to help grow this community. So you'll see us starting to do drawings for the webinar event, the courses. We've got a book coming out in about a month. We'll be offering that. Even full-blown evaluations, providing those for free for folks that, again, help us grow the community. So if you'd like to find out what the most recent rules are for the most recent drawing, just come to the membership page. Thank you for your interest.